Now, we're going to get into this ventricular arrhythmia business here. We talked about supraventricular arrhythmias before. They're small fry compared to the significance of ventricular arrhythmias in most cases because these kill folks. Supraventricular arrhythmias usually don't do that. We can kill folks with our treatments as well, and that's usually kind of on the blacklist of things. And also important is that people's patients and families and nursing staff see stuff on monitors that cause them a lot of concern, but are really benign disorders. We can't get too wrapped up in those. So as Dr. Zimmerman had said, and as I had said before, treat the reversible stuff, treat the cause instead of treating the arrhythmia so much in many cases, and we'll move on from that. Now, there are several types of rhythm disturbances that occur in hospitalized people. Of course, there's PVCs. Those are pretty much ubiquitous in the population. We wouldn't have a population problem if they were really that dangerous. People would be dying all the time, but it's just not happening. Then there's monomorphic ventricular tachycardia. These are in several categories. We'll talk about these. And their subtypes. Polymorphic VT is a different animal. And of course, ventricular fibrillation. Now, much of what we deal with, unfortunately, is separating real from unreal and true from artifact. And so I'm going to start with a couple of slides on how to distinguish artifact from real stuff on an ECG. So here's your real ventricular rhythm disturbance. Here's what it masquerades as it. So PVCs are masqueraded by PACs with aberration. That's usually not too much of a problem, but we'll see some examples of that. Monomorphic VT can be mimicked by SVT with aberration, pre-excited tachycardia, some other things. These guys are commonly mimicked by artifact, and usually it's not too much of a problem, but when it's a non-sustained episode that you see, that can lead to different evaluation, different treatments that are probably not necessary. So before looking at doing a big workup on ventricular arrhythmias and treating them, it's important to make sure you've got the diagnosis right. Some of that will depend on retaining any recordings that you have that are suspicious for this sort of thing and getting a correct diagnosis established. If you start down the wrong path, you'll start getting into some unnecessary, expensive, and sometimes risky testing for something that is a phantom. And importantly, as you're painfully aware from the medical record nowadays, once a diagnosis is made, it's there. It's really difficult to eliminate a false diagnosis. It just gets perpetuated in the EMR. And you can also get distracted from real care by these things that are really not important. Now, so how do we distinguish these? Well, there's some easy ways to look at these things. If you see a flat line on an ECG, most ECGs that are really, really flat line asystole are not flat. They are not drawing a straight line across the paper, but ECG artifact is that way. People have respiratory variation, respiratory motion, body motion, artifact from electric lights and so forth if it's a truly asystole with a good recording. But artifact can be just straight flat. Tiny ripples on a flat line suggest that there might be a dampened QRS. You have a totally flat, and then there's a little blip in it, totally flat, little blip. There might be a dampened QRS or T wave in there. Sometimes you'll be able to see high amplitude recordings that look like VT, but you'll be able to see QRS complexes that with the calipers will march right out through there. Sometimes you'll see what looks like a P wave or a QRS complex that cannot possibly occur that early after a prior P wave or QRS complex. So it has to be artifact. You'll have a pulse ox or an intra-arterial recording that persists with nice tracings despite asystole or VT or something else. And another important clue is if, as I'd shown on a previous slide, if you see some wiggling on the ECG before or after the area that looks like the real arrhythmia, that might be a clue that you're dealing with some artifact. This is true bradycardia versus simulating artifact. I think I will leave that to your reading for a little bit later since we're running just a little behind with things here. Here are some examples, however. Here is somebody who is coming along with some what looks like a PVC here, maybe it's a PAC with aberration, and then a couple of episodes of polymorphic VT, really rapid stuff here. And that's pretty scary looking. It looks, it looks pretty real, to be honest with you. If I just had this to look at, you'd have to spend some time with it. But we got the pulse ox going along here, and it's not too disturbed by what's going on. So this is artifact. It could be toothbrushing. It could be somebody positioning the patient or puffing up the pillow or something. This is a little bit more straightforward here on this one, especially having the red dots handy. But you can march out these normal QRSs that are underneath all the rest of this stuff, and it gradually dampens down here. And you see a kind of a wandering baseline to begin with, and at the end, those are clues that there's maybe some artifact, ECG artifact, at least as part of the mix, if not the whole solution here. Now, separating PACs from PACs with aberration from PVCs, not such a big deal really, because who's ever died from a PVC or a PAC? But they may be clues that more sustained episodes of wide complex tachycardia may be going on. And this is really an initiation and termination phenomenon that we'll see a little bit later. The width of the QRS, this is just like a distinguishing VT from SVT with aberration, a little bit wider with PVCs than with PACs. The interval from a prior QRS, if you're having a bigeminal looking rhythm, with PVCs, they tend to be more constant than our PACs. That's not, I wouldn't say that, oh, if it's constant, it can't be PACs. PACs can be a fixed coupling interval as well. A compensatory pause after the wide complex beat is almost always present with PVCs, but not with PACs. This is because PACs will reset the sinus node, and so the next QRS complex will come in a little bit earlier. It won't have a compensatory pause twice the previous RR interval, whereas most PVCs do not conduct back to the sinus node, therefore they don't ever affect it. The next P wave comes right on time. The initial portion of the QRS complex looks different than a normal complex does, most typically with aberration, whether it's left or right bundle aberration. We'll see it in a couple of minutes here. The initial portion of the QRS is not too terribly perturbed, whereas it is with PVCs or ventricular origin. And a retrograde P wave after the QRS, if you can see it, it's sometimes present, and it's almost never present after an aberrated complex for pretty obvious reasons. Now, here are some examples here. So just a 3-channel Holter monitor that somebody had, and they had some premature beats coming along here. So what are these? Well, we have these fixed coupling intervals on several examples that favors ventricular activation, ventricular origin, as opposed to supraventricular with aberration. Here is 1 RR interval. Here is the measurement of 2 RR intervals. So this is a totally compensatory pause here. And the initial QRS is different vector than the initial portion of the QRS during the abnormal beat is different from the normal beat. That suggests also. So we've got 3 reasons here to suspect that these are PVCs, and I think that's pretty good. And the other thing that is not shown on here is if it's a PAC with aberration, where's the stinking PAC? It's not up here. We see 3 different leads here, and there's no A in front of either of these. It's supposedly causing the QRS. Now, this is moving on to wide complex tachycardia. This is a real important problem in the critically ill or ICU setting patient. And the important thing from here is not all this stuff up here, but this big chunk. So I tell my fellows and residents, if somebody calls you up and says, hey, I got this person with a wide complex tachycardia, you say, stop, it's VT. You say, well, I haven't told you anything else. Hey, 70% of the time I'm going to be right, just out of the box. That's better than you can do in the stock market, certainly than the weatherman, pretty much anything else. The next most important thing here is what's left. Well, once you've gotten rid of that and you're still pondering what it is, most of the rest of them are going to be supraventricular with aberration. Some are going to be paced, some are going to be hyperkalemia, some are going to be WPW. But by and large, this is your differential. So most of the questions that we have, most of the criteria that have been developed are separating these 2 diagnostic entities. And I will leave most of this to your reading as well. I don't think you're going to see many examples on your examination. I don't even have too many examples on our examinations, just a couple here and there. But there are some things that are useful. There are more recent developed criteria, about 6-7 years ago. We had a paper on the QRS and lead AVR, the kind of the forgotten ECG lead. AV dissociation is you're hang your hat on it. If you can see it, and if it is a reliable diagnosis, it is ventricular tachycardia. If you can for sure see dissociated P waves, quite often there's AV dissociation, but you can't see it on the ECG because there's too many QRSs or too much ST segment T waves. So it's there, but not evidence. So that doesn't help you. It will just not almost ever be seen in supraventricular tachycardia. I've been doing electrophysiology for 30 years. I have a couple of cases of SVT with AV dissociation, so that's not likely to be bothering you too much. Let's see, not too much else in here worth looking at this point. We'll see some examples here subsequently. Now, one advantage you have in the hospitalized patient, as opposed to the emergency room patient or the outpatient, is you can see how an episode starts because you have it on telemetry, on the recording system, and this is very important in many cases. So if you can see the onset of an episode and the first thing you see is a P wave that initiates it, it's very unlikely to be ventricular tachycardia. It could happen by coincidence, but not likely. Much more likely to be SVT with aberration. The so-called long-short or short-long sequence, this is especially during atrial fibrillation, but you're coming along with a relatively rapid rhythm, and then there is a pause, and then a short interval, and after the short interval is when you have your wide complex. That's much more common with a long-short, sets the refractory period of the His-Purkinje system. The longer the long cycle, the longer the refractory period of the His-Purkinje system. So a short interval after that with a conductive beat is much more likely to aberrate. So long, short, aberration. And a short, long would not favor aberration. So if you see that as the initiation, that is much more common with ventricular arrhythmias. At the end of an episode, we're all glad to see the end of an episode, but if the last thing you see is a P wave, it's very unlikely to be supraventricular. So if you have an atrial tachycardia and it's causing aberration and then it stops, why should the last thing be a P wave that you see? Why didn't that conduct? It'd be very unusual to have AV conduction block exactly at the same time as the arrhythmia stops. So it'd be very unusual to be SVT with aberration, much more common with VT. If the last thing you see is a QRS, not so helpful, you will always see that with SVT with aberration and occasionally with VT as well, most of the time. The rate of the wide complex tachycardia versus when you saw it narrow. So for instance, if you have atrial fibrillation going along at 100 a minute and all of a sudden you have this blast of wide complex tachycardia at 240, it's very unlikely that that just happened to aberrate at that moment and then go back to the same rate. So rate parity during an episode is important as well. Most important of all of this stuff is not an ECG indicator, it's the clinical indicator. If the patient is looking well and feeling well, that means nothing as far as your diagnosis. Now, a lot of ER guys get this voodoo about, oh, they looked pretty good, so it couldn't possibly be ventricular tachycardia because all those people are sick. Nonsense. A lot of crossover between those two. So again, we treat the patient, not the arrhythmia, and how the patient looks is not an indicator of what your diagnosis is. Here is an ECG of a couple of patients here. One of the criteria that we have used electrocardiographically in the past is this so-called precordial concordance. That is, the V leads are all pointing in one direction. Here they're all pointing upwards towards, that means it looks like a right bundle pattern because V1 is positive, all the rest of them are positive. Typically, this is a pretty good indicator for being a ventricular origin because most cases of supraventricular tachycardia that have a right bundle pattern, it'll get smaller as you get across the precordium and you'll start developing some S waves in V4, V5, V6. If you don't see that, then everything is coming from the base of the heart. Most ventricular activation doesn't occur from the base of the heart without any form of aberration. So that's a pretty good indicator that it's not aberration, therefore it's probably VT. This case is VT up here. A patient with posterior infarct, infraposterior infarct. The same thing can happen, though, with WPW if you're conducting down a pathway because those connect atrium to ventricle way back at the base, at the mitral or tricuspid annulus. So all the voltage is coming out towards the V leads in those cases, especially with left-sided pathways. And this ECG I chose with a patient with a pre-excited tachycardia because the ECG looks almost identical lead for lead to this person with ventricular tachycardia. It's very difficult to tell those apart. And I wouldn't fault anyone for making a wrong diagnosis in that setting. Of course, the situation is important. If you come in with a 15-year-old who comes in with this ECG, pretty unlikely to be a posterior infarct-related VT in that case, much more likely to be pre-excited tachycardia. Similarly, in an 85-year-old who'd never had any rhythm disturbances before, been to the doctor many times and had ECGs that didn't show WPW, they're not going to be a pre-excited tachycardia most likely. This is a compilation of electrocardiographic criteria. The important thing with this is that when you have aberration, in most cases, the beginning portion of the QRS is not too disrupted from what it was at baseline. Now, if you have somebody, they're coming into the emergency room, you're consulted to see them, they have 1.0 ECGs, it's their wide complex tachycardia, you don't know what their baseline looks like, this is a difficult thing, it's irrelevant. But most people will have in their EMR an ECG that's normal, a baseline ECG somewhere. So SVT with aberration, the initial portion of the QRS, whether it's left bundle or right bundle, doesn't look too much different from the baseline normal complex, whatever it looked like. With ventricular tachycardia, those initial forces are perturbed or perverted somehow. They're per something. They're messed up somehow and different than normal. In aberration, we conduct down a portion of the His-Purkinje system, and the rest of the ventricle is late. So the beginning portion of the QRS is relatively narrow with aberration. The end portion of the QRS is a little slurred. With VT, it's just the opposite. The beginning of the QRS is a little bit wide, and the His-Purkinje system is engaged late in the system, so the end of the QRS is a little bit narrower. And we have criteria for that. We're not going to go over those. I think that's a very contrived or a very difficult comparison to make. Even though I was one of the authors on the paper, I don't like it very well. Here are two examples of VT on rhythm strips. The first one we see starts with a fused complex here. This doesn't look exactly like this complex nor like those complexes. So if you've got fusion, it's coming from two different sources. One of them is partially conducted. The other must be coming from the ventricle. And although there is a P wave before this first QRS, it's too short to be able to conduct. We know what PR intervals look like in this patient. This can't have conducted here to this QRS complex. And as we go on along the way here, we see P waves that are retrogradely conducted, but not associated with every single QRS. So how does a supraventricular arrhythmia cause more QRSs than P waves? A little bit hard to do. On the bottom tracing here, we have the same thing. We have an abnormal QRS that is not preceded by a P wave when we have opportunity to see P waves. And in fact, we see P waves after the QRS, not on each occasion. So this is VT in a couple of different ways. PVCs, as I said earlier, are ubiquitous in the population. They typically don't cause much concern if you don't even know they're there, but now that we got monitors on, we can get bothered by them. They have several diagnostic features that we've talked about previously here. They can occur randomly. They can be increased in frequency with low potassium. Rarely does ischemia cause these, and there's a zillion people with ischemia without PVCs, a zillion people with PVCs without ischemia, so that Venn diagram doesn't intersect very many times. They have not much clinical significance, a very mild decrease in cardiac output if just isolated PVCs, because the post-PVC beat is a little bit longer, a little bit stronger stroke volume to it. But larger stroke volume, and so cardiac output is not usually compromised. If you have more than about 15% of all your beats being PVCs, this may cause a cardiomyopathy. It's not a tachymyopathy, it's an abnormal ventricular activation myopathy. We get excited about that because we can treat those people. Rarely can PVCs cause VTVF. They certainly can, but there's a lot of PVCs out there, and somebody who has by Gemini has 50,000 PVCs a day, 100,000 beats in a normal day, 50,000 PVCs, 50,000 chances to kill yourself every day, and you missed. That's not very good. So they just are not a very common cause of VT and VF. Acute therapy, treating the underlying cause, if there is any, most of the time they're better ignored than eliminated. And the longer-term therapy depends more on symptoms than on actual risk, and there is a significant association between those two. All right, monomorphic ventricular tachycardia, each beat looking the same as opposed to polymorphic VT or VF. These come in two broad categories. One, you can say where structural heart disease is present, and that is the substrate in which these exist. That's a bad actor. Another is structural heart disease absent. First, when structural heart disease is present, it is almost always due to reentry. There's scarring separating normal myocardial cells. There's an insulative barrier and a path around this scar with just a few myocytes remaining. Myocardial dysfunction is often present because of an original injury that set up the substrate for VT. A lot of comorbidities exist in these people with peripheral vascular disease, diabetes, and that constrains your drug therapy in some situations. Constrains your procedural therapy and others. Hemodynamic tolerance of episodes is quite often poor, and the prognosis is poor, but more related to heart failure than sudden death in many of these cases, and the underlying disease and other infarction. So, in structural people who have VT in the absence of structural heart disease, a completely different disorder. These are much more akin to SVT, and we don't assign much malignant potential to SVTs. There isn't much malignant potential here either. These typically have a focus as their origin. There are some rare exceptions to that. Myocardial function is typically quite normal in these individuals. Their hemodynamics during VT are a little bit better in most cases, depending on how fast it is, and their prognosis is very good, very unlikely to drop dead with this disorder. In the presence of structural heart disease, these have wide QRS, very wide QRSs, much wider than baseline. They may be non-sustained or sustained, most typically prior myocardial infarction or cardiomyopathy. Rarely a catheter in the heart tickling around. Rarely hypokalemia. Fixing the ischemia or fixing hypokalemia is not going to fix this disorder. That's a cardiologist problem. We have poor thinking in many of those cases. That's typically not your problem. You're not going to be to blame for that. These are significant in that they cause low cardiac output, may cause cardiac arrest if deteriorating into VF, and so acutely you need to get these people out of their problem. If you treat ischemia and replete their electrolytes, that's wonderful to do, but it generally doesn't do anything for their ventricular arrhythmia. You need some antiarrhythmic drug therapy, cardioversion, ablation, something like that. Longer-term therapy, most of these people are going to end up with an implantable defibrillator, maybe with some adjunctive therapies as well. In the absence of structural heart disease, the QRS complex is not as wide and may be mistaken for SVT. Again, it may be sustained or not sustained. Acute therapy is with beta or calcium channel blockers, or in many cases, no therapy, especially if they're not terribly symptomatic. And long-term therapy, leave that to your electrophysiologic colleagues to decide what's the best way to do. Here's a couple of examples of ventricular tachycardia. This is somebody who's had an anterior infarction, and it's a left ventricular septal source. Here's somebody who's got a source of focal ventricular tachycardia just across the septum in the right ventricular outflow tract. And they look pretty similar, except that there's a lot more volts in somebody with no structural heart disease than in somebody who's had a lot of their anterior wall missing. Now, I mean, these are isolated examples here, and you don't know what this person looked like before. They may be very obese or have COPD, and they can have low R waves from that. So I wouldn't hang too much of a hat on that. Idioventricular rhythm. This is a very interesting disorder. It's not very common. More common in the monitored ICU patient who's asymptomatic than in the free-living creature, because it tends to occur in reperfusion after infarction. And some catecholamines where the ventricle just decides to go a little bit faster than the sinus rate for whatever reason. It's just a nuisance. It walks in and out of the monitor, and it typically doesn't require any treatment at all. Here's an example of it here. We have some fusion complexes here at the beginning, and as this rhythm stays stable and slow and the sinus rhythm picks up, the sinus rhythm will override it. Some more fusion beats on the way out. Just a curiosity more than anything of great importance here. Polymorphic VT, a very different disorder. This is where the QRSs do not look the same. This is distinct from a monomorphic VT, and then they have a second episode of VT that looks different from that. It's still monomorphic. We can call that pleomorphic or something else. But polymorphic VT is where no two adjacent QRS complexes look the same. They change from beat to beat. This, again, may be sustained or non-sustained. Very important to know what the QT interval is. The acquired in the hospitalized patient because of drug treatment is much more common than the congenitals, especially in older individuals. The congenitals will have been sorted out earlier in life. Many of these people have severe left ventricular dysfunction. Ischemia can cause this as opposed to many other things. It has major clinical significance. You may end up with repeated cardiac arrest and a patient who's in very much trouble. Removing the offending cause is great. If you have a drug, an antibiotic, or some other medication that's causing this, you can stop the med. It's still around for a while. You got to deal with it otherwise. If you think ischemia is a cause, then beta blockade is obviously important. Otherwise, isoprosternol may be helpful, just the opposite of beta blockade, in shortening the QT interval and preventing pauses. Long-term therapy depends on the cause. Almost always you're going to involve electrophysiologists in that. So here's an individual up here with a long QT related to cardiomyopathy and heart block, and here this QT interval is really slung out here, 0.6 seconds, and they have this little buzz of polymorphic VT, and it stops. This may cause some lightheadedness, may cause syncope. It usually will stop on its own. The thing that gets this going on a cellular basis gets eradicated with faster rates. So it's a bradycardic dependent phenomenon. That's why it tends to extinguish itself. This is an individual who's had a little bit of an inferior ischemia here, a little bit of ST elevation, and he has polymorphic VT that also stops by itself. Very different pathophysiology, very different treatment. So knowing what your QT interval is and whether there's ischemia or not is a very important fork in the road here. Ventricular fibrillation, the most baddest of all these actors here, easily recognizable on the ECG. Most people don't get 12-lead ECGs of this. It's just seen on a monitor. It may be sustained or non-sustained again. Severe ischemia early in the post-infarct phase, it doesn't tend to have much long-term prognostic badness associated with that. But if it occurs much after that, after 48 hours, it can be a recurrent problem. Certainly it's lethal if it's sustained and not quickly corrected, and it can be recurrent, and you really need to get a handle on that. Obviously, defibrillation is important first. Do your ACLS, revascularize if the shoe fits. Autonomic blockade may be necessary, maybe need to get stellate ganglion blockade. Really involved stuff if it's recurrent. Long-term therapy certainly depends on the cause. Here is a 12-lead ECG of ventricular fibrillation. Don't get this too often. This is a person with WPW who degenerated into VF, was nice enough to stay there long enough for us to get a 12-lead ECG and then do asynchronous defibrillation. So question number one, this is a 49-year-old with a COPD exacerbation in the ICU, and he has had atrial fibrillation in the past. What is the cause of the wide complexes seen in the middle here? VT, aberration during atrial fibrillation, atrial flutter with pre-excitation, or don't know. Okay, atrial fib with aberration is correct. If we go back to the slide here, we see the rate during this wide complex stuff is not too different than the rate during the otherwise normal. We have this long, short. It's a setup for aberration, and we have this baseline atrial arrhythmia going on. So a lot of different ways to put this together with the correct diagnosis, and you guys are doing really well with this. Okay, a 53-year-old with GI bleeding in the ICU. He has these recordings shown, and what should be your next step? Get potassium level and replete it, give amiodarone, and then an infusion, draw serum troponin. It's always going to be abnormal in the ICU, or continue monitoring. No music? Okay, well, we had some red dots up there, and that means something, and we continue monitoring because this was a fake. This is artifact. It's not very bad artifact, but you can see some clues on it here. There is, I don't know if I've got, no, sorry, I have to go back here. you can see, you can march through the real QRS is through here. I don't have my red dots on this screen here, but there's some other artifact going on. There's some impossible things that don't look like real ECG along in here, especially at the end there. So there's a lot of ways to put this together as artifacts. It's important to separate that out rather than getting started on this long road down the rabbit hole that leads to nowhere. So in summary, ventricular arrhythmias are common in our ICU setting, come in different forms. They may be transient benign, they may be malignant, and something that really needs to be very aggressively treated. Making a correct diagnosis, as in all of our cases that we've seen throughout this conference, is pivotal. Getting real from artifact is important. Getting VT from SVT separated is important. Getting an idea of whether they have structural heart disease is a very important break point as to whether it's a benign or a malignant problem. Reversible causes should always be sought, as we'll talk about in the next section here, and you may need help from an electrophysiologist if you have that asset available.